so many people already.
I'm ready now.
Great. Well, afternoon, everybody. It's just gone midday. We've 1 minute past. We'll give people a couple more minutes to join us while I just introduce this afternoon's session. But welcome to today's Respiratory Matters webinar. Thank you for taking the time to join us this afternoon. For those who don't know me, I'm Jo Oliver. I'm the Network Manager for Respiratory Conditions at NHS Wales Performance and Improvement. And it's great to see so many of you here today already. These sessions are all about bringing people together, sharing learning, supporting improvement across respiratory services in Wales. And whether you're a regular attender or joining us for the first time, we really hope you find today's session useful and informative. So just a bit of housekeeping before we get started, if that's okay. If you can, just keep your microphones muted and your cameras switched off during the session, that'll be great. We are recording the session, and the recording will be shared on our Teams channel and our Respiratory Network website shortly after today's webinar. So if you've got colleagues that weren't able to join us, they'll be able to listen back and watch the recording. If you've got any questions as we go along, just pop them in the chat, and we'll keep an eye on those and come back to those questions at the end of the session, if that's okay. And if there aren't any questions we're able to answer, or if we run out of time, we'll follow up afterwards with answering those questions. Just a quick reminder that we can issue certificates of attendance for today and for those who join us live. And if you'd like a certificate, just let us know in the chat before the session ends. Unfortunately, we're not able to issue certificates after the webinar or for those watching the recording, as we can obviously only verify attendance on the day. So hope that's helpful for you. And yeah, just drop your email address in the chat bar. So today's session, we're focusing on lung cancer screening in Wales. As many of you will know, lung cancer remains the leading cause of cancer-related deaths in Wales. There's now a strong evidence that targeted screening can make a real difference by identifying cancer earlier when treatment is more effective. This session is a great opportunity to hear about where we are in Wales so far and what the next steps look like as we move towards a national screening approach. So I'm really pleased to introduce our speaker today, Dr. Sinan Eccles. Sinan is a consultant respiratory physician at the Royal Glamorgan Hospital and respiratory clinical lead for lung cancer screening at Public Health Wales. He's been closely involved with progressing this work at a national level and brings a huge amount of expertise and insight into today's session. So thank you, Sinan, for joining us. I'll just hand over to you, and really looking forward to having the update today. Thanks very much.
Thanks for that introduction. That was very kind. I will share my slides. Yeah, so as you've heard, so I'm a respiratory consultant in Royal Glamorgan Hospital in Cwmtaf. So I wear that hat for half of the week, and then the other half of the week I am the respiratory clinical lead for what is now the lung cancer screening implementation programme for Public Health Wales. So this is what we're going to cover today. So I'll talk just briefly about lung cancer in Wales, the current state, talk about the evidence for lung cancer screening and a bit about policy. I will talk about the operational pilot that we did, and then how that has led to the planning work for a national programme. And then I think for this audience, particularly for the respiratory community, I'll talk a little bit about incidental findings from screening, which is something that often comes up. So you already heard that lung cancer is the biggest cause of cancer deaths in Wales. I think sometimes people don't quite realise the scale of that. So lung cancer kills more people than any other type of cancer, more than breast and bowel cancer combined every year. So it is a huge cause of mortality in Wales. And a lot of that is down to the stage at which we find lung cancer. So like most types of cancer, we talk about stage 1, stage 2, stage 3, stage 4. And stage 1 is usually when you've got a small tumour that's confined to the lung. Stage 2, sometimes it's grown or spread locally within the lung. Stage 3 is once it starts getting into the lymph nodes in the middle of the chest. And then stage 4 is when we've got distant metastases. So it may have spread to the other lung or to the liver or to the brain. Stage 1 and stage 2 we call early stage. Rarely causes symptoms at that point, and we can usually cure those lung cancers with surgery or radiotherapy. One of the challenges with lung cancer is you often only start to get symptoms once the cancer has progressed to a later stage. So that's when people present often with signs of brain metastases, for example, or when they're coughing up blood because the tumor has grown to a large unresectable stage. And the problem that we've got is currently half of our cases of lung cancer in Wales we find at stage 4. Almost 3/4 we find at stage 3 or stage 4. So it is a minority that we are finding at an early stage. And really those ones that we are finding at an early stage, we are largely finding by chance. So people are having CTPAs or CT scans for other indications. And by chance, we find a small nodule that turns out to be an early stage lung cancer. Your survival, if you're diagnosed with early stage lung cancer, is good. So if we find lung cancer at stage 1, almost all those people will still be alive a year later. Whereas you can see once you get down to stage 4 disease, the survival is really, really poor, even with the advances that we've seen in the various therapies for lung cancer over recent years. So why don't we just do some screening? So that's a question that comes up for lots of different things. There's questions about, should we screen for COPD? Should we screen for lots of other health conditions? So these two handsome fellows, Wilson and Jungner, were tasked by the World Health Organization in the 1960s to come up with some principles of screening. And this was one of the quotes from the report that they wrote. In theory, screening is an admirable method of combating disease, but in practice, there are snags. And the idea that just diagnosing things earlier is always a good idea is not true. So you have to fulfill these criteria for that to be a useful thing to do. So the thing you're looking for has to be important. We have to understand that there's an early stage and a late stage of that disease, that things get worse over time. Otherwise, there's no benefit of finding it sooner. There has to be a test for which we can diagnose that condition. The test has to be acceptable to the population. We have to have an agreed policy about who we treat when we find things. There has to be treatments that change the outcome of those conditions. It has to be economically viable. So the NHS does not have infinite money. So we have to be confident that setting up something like a screening program is going to be cost effective, that it's going to do more good than harm, and that is going to happen at an acceptable level of cost for the benefit that it would cause. So they set out these principles in 1968. And over time, lung cancer has accumulated the evidence to fulfill all of those criteria. So the two graphs on the left are two of the key studies. So the National Lung Screening Trial, NLST, was actually started in the early 2000s and then reported in 2011. So that was a big American study, 50,000 participants, randomized to either screening with a low-dose CT, or the comparator group in that case was chest X-ray, which we know from other studies is not kind of an effective tool to alter mortality for lung cancer screening. And they found a 20% reduction in lung cancer mortality by screening people with low-dose CT. That was enough for America to decide that they were going to have a policy of lung cancer screening. So from that point, you were able to get lung cancer screening on your health insurance in America. In Europe, there was a bit more of a cautious approach, and people weren't as convinced by that evidence. They were worried about some of the harms of screening. They were worried about whether those results were replicable. So a lot was put on this Nelson trial, which was, again, a trial of tens of thousands of people in the Netherlands and Belgium, so European setting, randomizing people to low-dose CT screening or to usual care, so no screening effectively. And they found similar results, so 25% reduction in lung cancer mortality with screening. And that happened because of the stage shift that you see. So the graph on the right shows what we usually see in Wales. So about 3/4 of our cases we find at stage 3 and stage 4. And then all those other bars are various lung cancer screening activities. So Nelson and NLST trials are on the far right, and then various UK pilots and programs that have happened over the years. And you can see it inverts the stage at which we find lung cancer. So about 3/4 of cases we find at an early stage, stage 1 or stage 2, if we find them through low-dose CT screening. Cost effectiveness analysis has been done as well. So this there's a body called the UK National Screening Committee who make recommendations about screening to the UK and the devolved governments. And they undertook some cost effectiveness analysis to try and work out whether this was going to be a cost effective thing to do. So the box that I've highlighted there is what you may think of effectively as QALYs, cost per QALY. So a QALY is a quality adjusted life year. So that is 1 extra year of living with good health. And usually NICE, when it's assessing things like drugs or other interventions, they will say that 20 to 30,000 pounds per extra quality year of life that you get is a reasonable thing for the NHS to pay. And you can see lung cancer screening comes in way below that. So cost estimates somewhere between £1,000 and £5,000 per QALY. So that gave us a template for how lung cancer screening could be done. It is a targeted screening, a targeted form of screening. So it is not for everybody. So breast cancer screening, for example, is for all women within the age range. Colorectal screening is for all men and women within the age range. Lung cancer screening is for people at high risk of lung cancer. Because we don't have evidence to show that it is effective in people who are at low risk of lung cancer. Most of that risk comes from smoking exposure. So this is broadly centered around people who are current and ex-smokers who have had heavy smoke exposure over the years. We do a low-dose CT scan on them to look for early signs of lung cancer or lung nodules. If you do that in a structured way, then you find 3/4 of your lung cancers at an early stage instead of a late stage. You can reduce lung cancer deaths by about 25%, as the trials have shown. It's highly cost effective, and there also seems to be a beneficial effect on smoking cessation. So it is a teachable moment where you can engage people who continue to smoke, and they are thinking about their lung health and their risk at that time, and it is a golden opportunity to engage them in smoking cessation services. So all of that evidence was enough to convince the UK National Screening Committee in 2022 that lung cancer screening should be recommended. So they reviewed all the evidence, did that cost effectiveness analysis, and this was then only the 4th form of cancer that they've recommended a national screening programme for, so alongside cervical, bowel and breast. There's been a lot of news about prostate cancer over the last couple of years about prostate cancer screening, and that did not meet the criteria that the UK National Screening Committee set out. So at the moment, there is still no recommendation for prostate cancer screening because the evidence has not reached the level to show that it is effective in the way that lung cancer screening has. So here's a timeline of what's happened so far. So that UK National Screening Committee recommendation came out in 2022. The work in Wales did start a little while before that. So the Wales Cancer Network commissioned some scoping work to look at lung cancer screening and lung health checks right back in 2019, which was when I first got involved writing that report for the Cancer Network. And out of that, we recommended that it would be useful to do an operational pilot in Wales to get some hands-on learning of how to do this, and for some national planning work to start in anticipation of a National Screening Committee recommendation coming. So I'm going to talk a little bit about the pilot first. So at the time, the thinking was to brand this as a lung health check. So England got started with it a little bit before we did, and it was branded as a lung health check at the time. Both England and Wales are moving towards being a bit more transparent and calling it lung cancer screening now that we've got the recommendation, but it was a lung health check at the time. And we did this in Cwmtaf, and we invited people from several GP surgeries to take part in the process, which I'll talk you through. So the objectives of the pilot were for us to get that hands-on learning, which would then give us insight into how best to plan a national programme, to sort of understand some of the bumps in the road that we'd need to overcome. To get a group of people who understood the process, so people like me, like our radiology lead, like programme managers and so on, who then understood what this involved, so then we'd be able to do it at a bigger scale. And then the other objective, obviously, was for the people participating in the pilot, we wanted to do them some good. So those were the primary objectives. The pilot was funded by a mixture of industry and third sector groups. So we didn't manage to convince Welsh Government to fund the pilot. So we had to go around cap in hand to various people, and we managed to get all the funding together in the end. And we chose North Rhondda as the place to do it. So that is an area of high levels of socio-economic deprivation. There are high smoking rates, high lung cancer mortality. So it makes sense to do it there, so you can do the most good to the cohort who you're inviting. We chose to do it for 60 to 74-year-olds, and we invited people who, on their GP record, it said that they had ever smoked. So we were looking for any positive current or ex-smoker code recorded in their GP record. Those people then had a telephone assessment to work out their risk of lung cancer over the next 5 years. So there's a series of questions that you can ask them, and it will generate a number to say this person's got a 5% chance of having lung cancer in the next 5 years, or a 1% chance. We define a threshold, and we say if you're above that threshold, you're high risk and you come for your low-dose CT scan. We had integrated pathways to help me quit. So everyone got asked whether they currently smoke, and then they had opt-out referral to help me quit. So the default was they were referred unless they specifically said that they didn't want to be. And they had the usual brief advice that we give to current smokers. And we were aiming to do about 500 low-dose CT scans as part of the pilot for that cohort. So these are some of the bits and bobs that we developed as part of the pilot. So we did a lot of work developing patient or participant information, so designing booklets, leaflets, setting up standard operating protocols for how we would manage findings and things, so we could make sure we did everything consistently. And those are now acting as the template for when we're developing things in the national programme. The CT scans were all done in a mobile scanner that we parked in the car park of one of the community hospitals in Llanapia. And we got off the ground in September 2023. So that poor lady there with the flowers was the first person who we screened in Wales. We didn't tell her that before she went into the scanner, but we ambushed her when she came out. And she was a good sport about it, thankfully. The picture on the bottom right is one of the screening scans that we did. So that's just to show that we use some software, some technology called computer-aided detection. So it's branded as an artificial intelligence type of thing that can read CT scans and can help identify and measure lung nodules. So that is something that is sort of slowly filtering into usual practice in Wales, but that was a standard thing that we did in the pilot, and it was standard in the lung cancer screening trials that had gone before. So I'll just talk you through what that process feels like for one of the participants. So Phil is a real person, and this really happened to him. So we sent him information in the post. We sent him a leaflet. We sent him a booklet and an invitation letter saying, we're going to give you a ring on this date at this time to talk to you about lung cancer screening and see whether you'd want to be involved in the pilot. He was a current smoker at the time that we enrolled him, so he had his brief advice and he agreed to be referred to help me quit, and he had conversations with the counsellors, and he then made a quit attempt and stopped smoking, which was great. when he came for his low-dose CT scan, you can see that there's a little orange box in the bottom right. So we didn't need the artificial intelligence to point out this one. So he's got an abnormality at his right hilum. So he has his CT scan that gets reported by our radiologists who were reporting for the pilot. And then that report comes through to us, and we gave him a ring to say there's something we don't like on your CT scan. So we're going to bring you in to the single cancer pathway for more tests. So that abnormality lit up on his PET scan. And he also had sort of various other tests as we would do in the usual workup of a suspected lung cancer. And we found that he had a stage 2 non-small cell lung cancer. So he went on to have surgery, video-assisted thoracic surgery, and had that part of his lung removed that contained the cancer. So he has had curative treatment for his lung cancer before any symptoms had appeared. So following that, he's quit smoking. We also found he had coronary artery calcification on his CT scan, so he's taking a statin for that. And then he's under our usual 5 years of surveillance that we would do following a radical treatment of lung cancer. We measured everything that we could measure in the pilot to try and make sure that we had as much data as possible for evaluation purposes. So this is one of the things that we were really proud of, is this is not, the people who are at high risk of lung cancer are not always an easy group to get to engage with sort of health benefit activities. So these are middle-aged and older people with a heavy smoking history or often continue to smoke. And they are not usually the ones who turn up for things like screening. You tend to get lower participation from those groups. So we did a lot of work before the pilot trying to look at what was happening in other places, what were bits of good practice in terms of invitation materials, communications that we did with people, the pathway to make it as accessible as it could be for the people who were inviting. And we managed to get an uptake of 58% for the risk assessment stage, which was higher than anyone else had reported at the time. So we were really proud of that. This is who turned up. So I guess from those of us who work in lung cancer clinics, we sort of get a skewed view of what the population is like sometimes, because often by the time people come and see us in clinic, they may often have metastatic disease, they may have lost weight. Actually, most of the people who are out there with a heavy smoking history are okay. So we talk in terms of performance status, which is a scale that people who work in cancer will be aware of. So performance status 0 means that you're pretty fit. 1 means you might have some symptoms that hold you back slightly, but you can do most things. 2, 3, and 4 means that you're a bit more disabled. And actually 90% of people with performance status 0 or 1, who are the ones who are usually fit enough to have radical treatment of lung cancer. And then similarly, despite the smoking history all these guys have got, most of them don't have a severe symptom burden from things like breathlessness. So the MRC score is on the left there. And you can see, more than 3/4 of the people have an MRC score of 0 or 1. So I guess it sort of lends support to the idea that if you're screening people and finding things early, you will largely get people who will be fit enough for radical treatment coming through. In terms of the cancers that we found, I showed you the data about what we usually see in Wales before, which is on the left there. So 3/4 at stage 3 or stage 4. And you can see we saw that inversion of the stage of lung cancers that we found through the pilot, which was great. But what was more pleasing than that is then what we were able to do with those lung cancers. Because just finding a cancer at an early stage doesn't benefit people unless you can then do something about it that's going to benefit them. So on the left, this data is maybe 2 years old now, from the National Lung Cancer Audit of what happened to non-small cell lung cancers diagnosed the same year that we did the pilot. So you can see less than 1/4 getting radical treatment, either surgery or radiotherapy, and the vast majority either having palliative treatment or best supportive care. Whereas the cancers that we found through the pilot, 2/3 having surgery, another chunk having radical radiotherapy, and only that minority then not being suitable for radical treatment. These are some of the incidental findings that we found. So I will come back to the incidental findings at the end, but this is what we saw in the pilot. So you do find stuff. Once you start doing CT scans, you will find stuff. But actually, because this is a largely asymptomatic well population, you don't find much stuff that is really significant. You find a lot of minor things. And as long as you've got a clearly structured reporting protocol to say this is significant and we're going to report on this and let people know about this, and these things are not clinically significant and we're going to ignore them, you can keep the amount of downstream work that you generate to a minimum. So you can see those respiratory incidental findings happened at a low frequency in the pilot, so less than 1% with significant findings. And we were also able to weed some of them out by reviewing people's medical records. So actually, if you find some bronchiectasis on the scan, what you don't want to do is refer them directly to the bronchiectasis service. You want to check, do we know about this already? Because actually, if you know about it and something's already been done about it, then you don't need to generate a new referral or a new action. We found other cancers as well. So we found a breast cancer, we found a mesothelioma, and we found a few renal cell carcinomas. So there are potential benefits for other malignancies alongside lung cancer, even if that's not the primary objective of the program. So these were the key performance indicators of the pilot. So the uptake I've already told you about, and essentially we hit all of the markers that we'd set out before the program to try and maximize the benefits and minimize the harms from screening. We've published 2 evaluation reports, so those are on the Cancer Network website, and I think that we'll put the link in the chat. But essentially, the pilot gave us assurance that this can be done within the Welsh healthcare system. There isn't anything particular about it that means this won't work here. It's likely to yield benefits similar as would be seen in the programs and studies that have been done elsewhere, and that it would lead to quite a big shift in what we see in terms of current lung cancer outcomes and lung cancer mortality. So I said alongside that operational pilot, we started doing some national planning work. So it took a little while to agree how that was going to be structured and who was going to be doing it. And in the end, the agreement was that Public Health Wales would lead on that because they deliver the other national screening programme. So it makes sense that they have that institutional knowledge of how to deliver screening on a national scale, that it would make sense for this to sit with them. So there was a pretty intense 12-month period of work to produce this report on the left, which outlined how we thought a national lung cancer screening programme could be delivered in Wales. That went to Welsh Government, and a few months later we had the thumbs up from Jeremy Miles, who was the health minister at the time, committing to development of a national lung cancer screening programme, which was great. So following that green light from Welsh Government, that team has then moved into a preparation phase. So we are now trying to put that plan in action with a view to getting the programme live. These are some of the key things that were in that report that we're working towards. So I guess the first thing is the name. So I mentioned Lung Health Check before. I think we have settled on a name of Lung Screening Wales now, so it will be aligned with Bowel Screening Wales and the other screening programmes. It'll be a phased rollout over a number of years. So the UK National Screening Committee say that this will be for 55 to 74-year-olds. We're going to start at the upper age range of that and then work down until we reach the full cohort. So that's similar to how bowel screening has been rolled out in Wales to reach the full cohort. There's a lot of work to do with the digital systems. So procuring an administration system to underpin the whole programme is one of the most complex tasks in the whole planning phase, really. There will be centrally delivered telephone-based risk assessments. So Public Health Wales will organise that, but obviously that doesn't need to be done locally. That can be done from a single centralised place. The lung cancer risk assessment will be the same that we did in the pilot and is being done in the English programme at the moment. So we use 2 multivariable tools to project people's risk of lung cancer and use the defined threshold for who is high risk and gets a CT scan. There was clear feedback from the health boards that they did not have existing spare CT capacity to take this on. So part of the work is going to be procuring a fleet of mobile scanners that will go around Wales to deliver this, similar to the Breast Test Wales units. And similarly, there is inequity in thoracic radiology workforce across the different health boards. So the fairest way to do the reporting is that we will have a single queue of reporting that everyone contributes to. So say if Hywel Dda's only got one thoracic radiologist and they're off sick, for example, that all their scans don't suddenly stop still. We'll have a single queue for the whole of Wales that everybody works through. Screening review meetings I'll talk about on a later slide, because that's something that will be coming to each of the health boards in due course. The standard recall interval will be 2 years. So if you're eligible for a scan, you have a normal scan, then you will have another scan after 2 years, similar to how you have another mammogram after 3 years, up until you reach that upper age limit and you age out. And any lung nodules that are found within the programme, if they need a repeat scan sooner, after 3 months or 12 months, for example, that will be done within the programme. And then Help Me Quit I've already talked about, so there will be direct links from the programme to the Help Me Quit service. These are some of the people who are involved, so you might see some of these names come up over time. So Meng is the Executive Medical Director in Public Health Wales, so he's sort of ultimately responsible for everything. Heather is a public health consultant, and Chris was our programme manager for the pilot and is now the head of programme for the implementation programme and will be for the programme when it goes live. And then there's a group of us who are leading on various different things. So I'm on the respiratory side. Tim Pearce, who's one of my colleagues in Cwmtaf, leads on the radiology side. And we've also got a lead radiographer, lead nurse, and a huge team of other people scattered across the bottom there. It really is a complex program to try and set up. So there are a lot of people involved, which is great, really. Just to take a broader view of the UK of where everybody is up to. So England jumped the gun on lung cancer screening. They started their lung health check programme before that UK National Screening Committee recommendation came, which was a bit of a gamble really from NHS England, but it's a gamble that paid off in the end, because the recommendation did come, but it means that they're in a more advanced position than the other nations. So they launched their programme in 2019. After doing some pilots in the decade previous in Manchester, Liverpool, and some other sites. They're covering about 50% of their population at the moment, and their aim is to get to 100% coverage by 2030. I've already talked you through what we've done. So we're aiming to launch in 2028 with then a phased rollout over 6 years. Scotland, I think, are at a sort of similar stage to us, but probably a little bit behind. They've not quite got the same level of commitment, I think, from their government yet, and they don't have quite as clear a plan of how they get to implementation, but they have done pilots and they have got some active planning work going on. Northern Ireland are still just about finding their feet with this, I think, and haven't progressed very far yet. This was just a bit about screening review meetings and what the implications for health boards might be, which is obviously where lots of you work. So this is just trying to demonstrate what the divide between what Public Health Wales is going to do centrally for the programme and then what will spill out into the health boards. So that risk assessment bit, the calling people, the identifying people, the CT scanning and the CT reporting will all sit within Public Health Wales. So that will be a sort of self-contained programme. Where the health boards get involved, and this will be commissioned by the screening programme for the health boards to deliver, are screening review meetings. So if we find something on the scan, so a suspected lung cancer or a significant incidental finding that might need an action, then they will get discussed at a screening review meeting within the health boards, where you can check previous imaging or health records to see, is that a new finding? What do we need to do with it? And then if it's a new finding, then that team will then link it up with whatever pathway it needs to be linked up with. So either the lung single cancer pathway, or if they need to come to a general respiratory clinic, if they need to be referred to an endocrine clinic for an adrenal thing, whatever, they will get linked up with those local pathways. Lung nodules that need follow-up, like I said, will come back into the program and be followed up on those mobile scanners and through that same reporting system. Just a little bit more about incidental findings. So I talked about the bit at the bottom, the low frequency of other respiratory findings already, and that's because this is a largely asymptomatic population. In screening, it is reasonable to have a higher threshold for reporting things than in the symptomatic setting. So if you are looking for if someone comes and sees you about a chronic productive cough, and you do a CT scan and they've got some bronchial wall thickening, then that's clinically relevant in that setting because you can say, okay, yeah, this is probably what's causing it. Whereas in the screening setting, the primary function of the scan is to look for early stage lung cancer, and minor findings like that, it is reasonable to dismiss. The CT images will still be there available for people. If that person then turns up with symptoms further down the line, you'll be able to review historical imaging in the same way that you would when imaging has been done for other reasons, but we don't want to be actively pursuing all of those minor findings. Emphysema is a tricky one because it is very common in this cohort. So what we saw in the pilot is on the bottom pie chart there. So you can see more than half of people had some emphysema visible on their scan, with the majority of it being mild. It is important to distinguish that from COPD. So COPD is defined really by airflow obstruction, and some people have radiological emphysema without airflow obstruction, some people have airflow obstruction without radiological emphysema, and some people have both. And it's important that they don't get interchanged to think all these people with mild emphysema need inhalers and pulmonary rehab and all that kind of stuff. They need to be thought of as two different things that have an overlap. And there are harms of overdiagnosing people. So actually, if someone's not really got any limiting symptoms, they don't have exacerbations, and they've got mild emphysema on their scan, all they need is smoking cessation advice. They don't need all the pharmacotherapy and everything else that goes with the COPD diagnosis. So the way that will be dealt with for the milder ones will just be standard advice on results letters rather than actively linking them up to pathways. The group who we really need to do something about are if they've got more severe emphysema than that on the scan, and they don't have a prior COPD diagnosis, but they have got symptoms. And I think that's one of the key discussions with the respiratory network over the coming year or two, is to work out what the best way of doing that is. Primary care are already overloaded. It may be that the breathlessness hubs that are getting set up over the coming years might be a good conduit for this. I guess I've already partly explained there is a lot there is a lot to sort out before we get to the program launching and going live. Digital is probably the thing that presents the most headaches because it's not completely in our gift. We're dependent on other agencies to help us sort things out, and that is challenging and it's complex, and there's a lot to think about. So that's one of the key challenges. There's things around the logistics of moving mobile CT scanners around Wales, things like wireless connectivity to transmit scan results back from those scanners. Workforce is always a challenge. This will be a new workforce obviously coming into place, so we're working out what the best way of handling that is. Downstream capacity of services we're always worried about, so that's why we're trying to minimise the impact of things like incidental findings. And there's discussions with Welsh Government and the health boards and with the Joint Commissioning Committee about implications for things like PET and thoracic surgery to make sure those services are prepared as they can be. And then one of the other challenges is to do with deprivation and like I described earlier, getting the right people to turn up for this. So we want the people at high risk of lung cancer to be the ones who are coming. And in screening, the tradition is it's the exact opposite of that. So it's people who are at low risk, who are health conscious, who are the people who are more likely to attend. And it's particularly important in lung cancer because lung cancer has a really wide deprivation gap. So you're much, much more likely to get lung cancer if you're from a socioeconomically deprived background, partly associated with the smoking association, partly associated with health-seeking behaviour. So people don't want to bother their doctor. People find it difficult to go to their doctor. these people are often they've often got other commitments, either family or work. They don't have that same autonomy to maybe make an appointment with a doctor and get advice that they need. So it's a challenge, but it is one that lung cancer screening can address. So this is some data from England that showed that black line at the bottom is the most deprived quintile. And you can see before screening really got off the ground, which was around 2021 in England, that group was most likely to be diagnosed at a late stage. So the lower you are on the graph, the more likely you are to be diagnosed at a late stage. And you can see as screening started to roll out, that black line rises up to the top. So actually screening is successfully getting into those people who are at highest risk and is leveling them up rather than widening that difference in deprivation gap of outcomes. It's always sort of worth taking a step back every now and then and remembering why this is important, because we do sometimes get bogged down in the numbers of it's going to be this many more PET scans and it's going to cost this much, and it's this difficult to get DHCW to do this bit of work on digital for us. But it is worth zooming out every now and then and just reminding ourselves that thousands of people in Wales die of lung cancer every year, many of which could be prevented with a screening programme. So that's everything I was going to say. So just to sum things up, so lung cancer screening is clinically and cost effective. We've got all the evidence that we need. It's not an experimental thing. We know that it works and it's been recommended for implementation, and we have commitment from Welsh Government, the previous Welsh Government, I should say, I suppose, but from Welsh Government as a body to developing a programme. It is complicated. That is why it's taking a bit of time for us to get there, but we want to make sure we do it right, and we want to make sure it's safe and effective when it gets there. So that's why we're working through it. And the current aim is that we will go live in early 2028.
Fantastic. Thanks ever so much, Sinan. That was really interesting. Great overview of the evidence and obviously the pilot programme, the successes, and great to hear what the plans are for rolling out now. Really interesting, and thanks very much. We've got some questions in the chat bar, but if anybody does want to ask, put their hand up, raise your hand, and we'll start opportunity to fire away and ask Sinan any questions. Sarah, you've got your hand up. Did you want to go first?
Yes, hello. Based on Rhys Bjorth's inauguration yesterday and his commitment during his speech that he is going to focus on the Welsh NHS, which he made in both English and Welsh, do you think this will actually aid the speed with which screening is implemented?
Good question.
Yeah.
Topical.
So I think the honest answer is we don't know. I think the plan that we've got at the moment is, I guess as I've laid out, this is hard to get everything into place for. So you can cut corners, but that does leave you with problems further down the line. So one of the ways that England have managed to get off the ground so quickly is they have essentially outsourced huge parts of their pathway. So they have sort of industry partners from the private sector who deliver most of the pathway, and NHS England just pays them to do it. And there's advantages to that in terms of speed, but there are disadvantages in terms of quality assurance, control, and sustainability, I suppose, because when those contracts come to an end, which is starting to happen in some of the sites in England, they can pick a price because it's difficult to then change provider, and you're a bit stuck. So the sort of steer that we had from Welsh Government before is that we wanted this to be a truly public service, like a proper NHS service, and we would build the foundations of it with our own workforce, our own CT scans, outsourcing where we have to, if we have to plug gaps, if that's what means that we can get off the ground. But it was very much that this needs to be a public service. I guess over the coming months, we will see what the new government think of that. I think it's probably unlikely that that they would want to diverge significantly from that, partly because so much work has gone into the planning and the work to date that there's a time cost associated with then changing that plan. So I think it's probably the most sensible thing to do would be to try and see that plan through. I think, you know, there's always help that we could have to try and make sure that plan is deliverable on time. So, you know, making sure that is a priority of some of the other organizations that we're dependent on, for example, in terms of digital and other things, procurement and so on. So I don't think we know yet. I think we've sort of got enough momentum that I don't, you know, I think this is going to get seen through one way or another. But I think sort of sticking to the plan and seeing, I think the plan is a good plan, and I think seeing it through to its conclusion is hopefully the right thing to do.
Great, thank you. David from Betsy Respiratory has asked in the chat bar, will the patients need access to physiology service investigations? If so, has there been any work done on demand and capacity around this, e.g. ETT, spirometry, gas transfer and CPET? Thanks, David, for that question.
Yes, so as part of the work before we got that green light from Welsh Government, there was a lot of modelling work done about what we thought we would expect, and that included modelling of impact on downstream services, particularly lung cancer investigations. So things like EBUS, thoracic surgery, PET, lung function, and so on. So those figures were all, we had named representatives from each of the health boards as part of that body of work, and we shared that with all of the health boards and had feedback from them. I think, you know, to very briefly summarize the feedback, nowhere is sort of sitting around looking for extra work. I think that NHS as a whole feels under strain. I think that you can mitigate some of those surges in work by how you roll things out. So that's how that influenced the phased rollout that we're proposing to try and avoid a very rapid surge of patients coming into the system. So we wanted to try and smooth that over. One thing that's important to remember is screening doesn't make new lung cancers. These lung cancers were all there and they were all coming to you sooner or later. But they are going to come to you at an earlier stage, and that does shift what you do with them. So for stage 4 lung cancer, we wouldn't always do lung function, for example, because it's not, it doesn't influence what we do, whereas you will need that for early stage lung cancer. Thoracic surgery and PET are probably the biggest two that it will affect, I think. So we've had specific engagement with JCC, who commission those services, and with the health boards that deliver them. So they're sort of well aware of the plans, and the health boards are aware of the plans in terms of what will affect them. What those health boards do with that information, I guess, is dependent on the health board, and I think everyone struggles with capacity of the things that they've got, but we have shared that information with them as much as we can.
Great, yeah, and again, you're right, these patients are going to be needing treatment for lung cancer anyway. You're just bringing that treatment forward and getting them seen so much sooner and getting the right treatment earlier, so that's great. Joe from Hywel has asked about incidental findings, and do the patients get told about those?
Yeah, good question. So I think we're still working through this. So if we take emphysema, for example, my view is that we tell everybody if they have emphysema, because I think it is a useful lever for smoking cessation. So in England at the moment, you only get told if you have moderate or severe emphysema, so you don't get told if you have mild emphysema. I think in Wales, our feeling is that we would tell them that they've got mild emphysema, but we would do it in a sort of structured way in that results letter to say, we found some mild emphysema on your scan. This is a common finding. You know, most people who we scan in this program have that finding. and then just give them some advice about staying active and smoking cessation or abstinence, depending on their smoking status. There's sort of a balance between telling people, but also reassuring them that, you know, this isn't something that they need to panic about. It's something that is almost expected, really.
Great, thank you. Let's have a look. Robert, did you want to ask your question next?
Yes, thank you. As a thoracic surgeon, sometimes we see very small lesions with patients who have had screening, and in MDT, we kind of try to determine whether the lesions look malignant or if they're growing or changing. And we depend on human expertise to see if those lesions are warranted to have a resection or a biopsy. Sometimes biopsies are very difficult in deep lesions surrounded by lung tissue that is emphysematous. So do you have any input from England? Are they trying to use AI to kind of get around this problem, or what is the numbers to treat sort of way to think about how many cases would essentially have surgery to turn out to not be cancer?
Yeah, so that was one of the concerns in the original American trial that delayed things, really, was they had a fairly high benign resection rate. So they were taking out nodules that turned out not to be lung cancers. Things have moved on a bit from then. So one of the things that's really helpful is the volumetry, so the measuring of the volume of the nodules to detect growth. So by having a really clear reporting protocol and having really clearly defined thresholds about when things are going to come from the screening program into the single cancer pathway, that's one step that can help. I think the sort of confidence of radiologists and the sensitivity and specificity, I suppose, to call something malignant or not malignant varies, and similar, as you know, for all clinicians across all specialties, their confidence at doing CT guided biopsies on smaller or trickier lesions varies as well. I think there are new technologies coming, so you know, navigational bronchoscopy, that sort of stuff. I think screening sort of lends there is benefits of those two things working together, and I think that's something that we need to be mindful of going forward. I think almost tied to that, I think there is a question about whether we could work better as a region, certainly in South Wales, to have some sort of difficult biopsy service or difficult tissue service. So that is something that they do have in some places like Manchester, for example, where at the moment in Wales, it's very piecemeal. So I know, you know, Hywel Dda have got a form of navigational bronchoscopy. Swansea have got a form of navigational bronchoscopy. Cardiff are trying to get a form of navigational bronchoscopy. But at the moment, each health board is sort of trying to piece together its own bit. And I do think, particularly for these more expensive, complex technologies, that there probably is a way that we could coordinate ourselves a bit better across, certainly across South Wales, to say, actually, you know, this centre is going to be the expert in this thing, this centre is going to be the expert in this thing. And then we have more of an MDT approach to try and direct people for the right investigation first time, no matter which health board they live in. Well, what I would say is, even without all that new technology, in England, by following quite clear sort of protocols for intervention, they have kept the benign resection rate really low. So there's a nice publication where they had less than 5% benign resection rate. So, you know, over 95% of what they were taking out were lung cancers. So they have shown that in practice with large numbers, they're able to maintain that quality, which I think is reassuring.
Well, I remember from my Brompton days that I suppose they would harpoon the lesion and for the surgeon to even see it during the operation and resect less lung. So I'm not sure if that's out of favor, or I think navigational bronchoscopy now, robotic navigational bronchoscopy is coming along and trying to diagnose those lesions.
Lovely.
And
Thank you.
AI, I suppose.
Yeah, AI is the way
AI will be
forward, isn't it?
implemented.
There's just a few more questions. I'm conscious we've just got 5 minutes left. Great questions coming in. Richard from Swansea, did you want to quickly ask your question?
Hi, Sinan. I hope you're well. We talked about this briefly before, but just to follow on from Robert's question about this kind of increase in hunger to get biopsies and histological evidence of malignancy, but rather than relying on scans and AI, etc. So I'd spoken to Robin Poyner in North Wales about the Illumicite system, and maybe having, like, as you say, like a hub and spoke model for difficult biopsies in South Wales. I won't kind of complicate my question anymore, but all I really want to ask is, when we're kind of discussing concerns about funding and capacity for services that we may need in the future, whom would you recommend is the best person to speak to? Should I speak to Chris about this? Should I speak to you about it? Is there a particular point of contact in, performance and improvement?
So they're two slightly separate things, really. So the screening program gets you as far as the point of suspicion. So there is a growing nodule or a lesion there that needs further investigation. And then the second part of that pathway is the single cancer pathway, where the investigations happen. So the single cancer pathway at the moment is the responsibility of the health boards, and then sort of coordinating that is the Wales Cancer Network. So it is the lung cancer strategy group within the cancer network who would be the ones who would sort of lead on that question together with your health board. So I guess it would be Craig Dyer is the chair of the lung CSG. So he would be the key point of contact, really.
Okay, that's really useful. Yeah, thank you.
Great, thank you. Just quick 2 questions from Jenny in Llandaff Surgery. Lung cancer cases are rising in never smoking women. Could you see this being rolled out to all adults over 55 in the future? And just following on from that, would having a family history of lung cancer also count as a high risk, especially if a family member diagnosed was a never smoker? Thanks, Jenny, for those questions.
Yes. So they're linked, really. So it's a question about eligibility and defining risk. So at the moment, all the evidence that we have from the randomized controlled trials is in people with a heavy smoking history. So that is the group where we have evidence to show that you will get a reduction in lung cancer mortality if you screen those people. The reason why you can't screen everybody is there are harms of screening. So we were just talking about benign resection rates. So that is putting people through thoracic surgery to take out a nodule that turns out not to be cancer. And once you start spreading the net wider, the chances of something that you see in someone's lung being a cancer are going down. So once you go into lower risk groups, that nodule is much less likely to be cancer, but you're still exposing people to the harms of invasive investigations, thoracic surgery, and so on. And we don't know that we would reduce mortality in those groups at the moment. I think the family history one, so that does play into those risk scores that I talked about before. So family history of lung cancer is a risk factor for lung cancer. There's no getting away from that. But at the moment, only really combined with a smoking history would get you above that threshold. So it plays into those risk scores, but again, only as part of that assessment for the people who have ever smoked. There's lots of research going on at the moment about other at-risk groups, particularly looking at biomarkers. So is there something that we can pick up in a blood test or a breath test or something like that, that gives us an indication of lung cancer or of other cancers as well? So there's been a trial called the Summit trial. There's a few other ones. At the moment, most of the evidence that has come out of those has shown that those blood tests can find cancers, but it only tends to find them once they get to a later stage. So I think people are still working on those technologies to work out, is there something that we could use to identify people without that heavy smoking history? But it is a research question at the moment. At the moment, we don't have the evidence to support doing it, and we need that evidence to consider it, really.
Lovely, thank you. Well, we've run out of time, unfortunately. Great questions coming through. Savita will follow up on your question about workforce after the webinar. But yeah, no, thank you ever so much for your excellent questions, and thank you so much for a really interesting presentation and sharing your time and expertise with us today. Really interesting and great to hear the way forward. Thank you to everybody who's joined us today and contributed, and thank you to my colleagues within the Respiratory Network. Fasako and Christina couldn't have done today without you, so thank you very much. Just reminding you that the recording will be available, and I can see so many people are asking for certificates, so we'll crack on and get those out to you. So thank you again. Any future suggestions for webinars, please do add them into the chat. This is an ongoing programme of education, so we want to be able to obviously carry on sharing knowledge and expertise. Our next session in June is going to focus on lung function testing with Hannah Hunt presenting, who's our physiology clinical lead. And again, we'll share registration links as soon as possible. So thank you ever so much again, and enjoy the rest of your day. And thank you so much, Sinan, for your time. Thanks, everyone.